Hello everybody and welcome to the HacettepePathology.com Case of the Month series. In this month I'm going to talk about two common soft tissue neoplasms which are commonly fall into their differential diagnosis and of course the distinction is important because of the important clinical management of the patient, because one of these cases diagnosis is a nodular fasciitis and the other one is synovial sarcoma. And the first case is from nodular fasciitis. As we all know, the clinics are different. Nodular fasciitis is you have up to 3 months or months fast-growing tumor, and nodular fasciitis usually doesn't exceed 5 centimeter. I mean, it's usually 2 or 3 centimeter, but almost never exceed 5 centimeters. And as you see here, we have the straight muscle, and this tumor is continuous with the fascia. You don't appreciate this I mean, you cannot appreciate this always in all cases, but it's a good clue. And the other clue is these irregular borders. I mean, sarcomas are usually not infiltrative, but they usually have pushing borders. But benign entities such as nodular fasciitis or the other fasciitis group of lesions, or for example desmoid fibromatosis, they have usually infiltrative borders like this. And again, some extensions into the fascia. And the most prominent finding of nodular fasciitis is these areas of degeneration. We can call it myxoid degeneration or small cystic degenerations, and these extravasated erythrocytes throughout the lesion. And here is a good degenerative zone or microcystic degeneration. At low power, you can simply and easily call this nodular fasciitis. And another important thing is the lack of vasculature or prominent vasculature. You may have some simple vessels like this here, but overall the lesion is vesselless. You can say the vessels are not prominent, and you may have these collagen bundles like this here. And when you go into further details, in the cellular details, you have this plump myofibroblastic, and you can call this like fibroblastic culture like, or I prefer the term granulation like tissue. And these are all plump myofibroblasts with inconspicuous nucleoli. And of course we may find mitotic figures depending on the age of the lesion, and we may say that this is an early kind of lesion, but we also have some burned out areas of this tumor. So this is nodular fasciitis, and I sometimes use SMA and desmin as nodular fasciitis is SMA positive and desmin negative in the small biopsies, just to prove the diagnosis. And this is a case, actually this is a younger patient, 15 years of age, and this is synovial sarcoma. As you see, this case has the borders are more well delineated. You may have some finger-like protrusions, but also they are not infiltrative, they are just pushing borders. They have pushy borders like this. And at first look, you may have these extravasated erythrocytes, but these erythrocytes, these areas are secondary to the previous biopsy. I mean, the one morphological clue is not enough to call something benign or malignant. And the other thing that pops out as the prominent well-formed vasculature in this tumor, and it looks more cellular than nodular fasciitis. You may have also some myxoid-like areas, but overall the lesion has lots of vessels, and the you can appreciate this sweeping fascicles like fibrosarcoma like fascicles, or some may also think that these are the palisades. And the other information or clue for the diagnosis is lack of pleomorphism and mitotic figures. I mean, mitotic figures are more prominent in nodular fasciitis, and here you don't expect to see too much mitotic figures in the synovial sarcoma. And this pattern is also called like group of fish. Some mitotic figures like here, and of course this lesion is larger than nodular fasciitis. And you may also expect some hemangioperistic like areas. I don't see here in this slide, but you may also find hemangioperistic like vessels, which is not compatible with the diagnosis of nodular fasciitis. You may also use EMA or TLE1 for the differential diagnosis, but in this case actually the diagnosis was quite straightforward. We only did TLE1 and some EMA and keratins to diagnose synovial sarcoma. Sometimes monophasic synovial sarcoma biphasic synovial sarcoma is morphologically diagnosable, except for the differential diagnosis of mesothelioma. But in the soft tissues, if you see biphasic synovial sarcoma, it's easy to diagnose without molecular. But here you may order molecular ancillary techniques to diagnose to confirm or support the diagnosis of synovial sarcoma. Thank you very much.